Welcome to So What, a Frontline podcast. Welcome back to part 2 of my discussion with Dr. Ken Milne regarding the use of sea collars. If you haven't listened to part 1, I highly suggest that you do so. Otherwise, you will be lost.
We should probably talk also about what are other places doing, because you mentioned Australia to me in a prior conversation, and maybe we can look to other places who have faced the same question and implemented different procedures and
Well,
policies.
so we can actually look back even further than Australia, because back when I was in the stacks and writing this paper, one of the early skeptics of spinal cord injury immobilization looked at Malaysia, where there were plenty of road traffic accidents, motor vehicle crashes, whatever you want to refer to them as, and no EMS. And they would bring people in clearly without any immobilization at all. And what they found was, lo and behold, there wasn't a higher incidence of delayed onset spinal cord injury in Malaysia. Now, plenty of confounders that would make that a very difficult paper to extrapolate with any certainty, but does suggest, and did suggest back then, that this may not be all it's cracked up to be. I mean, we should, with our 6 million or so cervical collars that we're putting on a year, and I'm pulling that number out of my tail end, but let's face facts, it's millions. I mean, it's millions of people that are coming in on sea collars in place. But we should have something to show for it, right? We should have so much less per capita spinal cord injuries than Malaysia, and we just didn't.
How many spinal cord injuries do you have a year in the US?
The last time I looked at the data, it was about 6,300.
Okay, so thousands, not tens of thousands, but thousands a year.
Yes.
Out of millions. So the
Yes.
agenda is in the obviously the numerator, those thousands of people, and the devil is in the denominator out of millions.
Let me be clear. I'm talking about spinal cord, not spinal column injuries.
Okay, yeah,
I have no doubt that we have many more
fractures.
The question of what I'm talking about is spinal column, neurological damage to the spinal column via trauma. Is
good to clear that up.
Is a very low number, and the reality is it's a relatively rare thing,
but devastating.
But devastating. Absolutely.
And that's the argument from emotion, right? That's the argument from emotion. Well, it's a devastating, rare injury, so we should be extra cautious and do the precautionary principle.
And we should not just stand. We should not just do something. We should stand there.
Exactly.
It's actually what we should be doing, but no one wants to do that because that's just not heroic.
It doesn't feed into our intervention bias. So we want to know that if we are immobilizing these people, that we're actually helping them. And you're suggesting that if anything, we're nudging them towards more harm because we know that it raises their intracranial pressure, and then that's not good.
Right. And I think that the other thing that we're ignoring is the fact that however you believe man evolved, whether be it from an intelligent being, a higher being, or pure chance, we evolved in such a way that we protect our own spinal cords.
Yeah, that's a whole other podcast on that.
That's a whole, and I'm not trying to go there, but the elegance and the beauty of the design is amazing. Like
most people that I've seen who have significant injuries, potential injuries, don't want to move their neck.
No,
and if I say, please don't move your neck, they don't move their neck because it hurts to move their neck. And those people on the other extreme are the ones going, don't you put that gosh darn collar on me and I'm not wearing it. They rip it off, they throw you. And I'm not talking about people who are suffering from substance disuse disorder, or are people that are delirious or septic, or I'm talking people who are like, I've been in a collar, Howie. I was hit by a delivery van when I was pumping gas. I think it was in the early 90s, and I was pumping gas at a corner gas station, and this delivery van cut the corner to avoid the red light and just happened to hit me. And so I go flying. There's gas everywhere. It's an episode of Zoolander, basically. And, they, of course, the paramedics come and appropriately check me out, make sure I'm okay. And, being, oh, I'm fine, I'm fine, I'm fine. I remember saying that. And I'm in shock that I just got hit by a delivery van and launched 10 feet, 3 meters. And they put me in a collar. And that was what they were supposed to do then. And if you didn't have pain in your neck before, ask your doctor if a collar is right for you.
Oh, absolutely. I mean, how many CT reports are we going to read that say straightening of the cervical lordosis, which is
Yes.
happening from this sea collar? That's brutal.
Yeah.
And to say
So
nothing.
I'm not berating the paramedics. Please don't take it that
No,
way.
well, first of all, I mean, look, I was a firefighter paramedic for 8 years before med school. I was in the days when we
You would
would
have
be
put me in a
standing.
collar?
Oh, absolutely. Collar and a board.
Oh no,
We,
I was
we'd
put
have,
on a board.
we'd have left you
Uh,
standing there. We would have secured your head like this.
Pedestrian? Yeah.
We'd have walked up to you and grabbed your head,
As I
squeezing it
was
between our arms
This is
and
what they did.
holding
As I
C-spine.
as I was dripping and in gasoline, just going, God, nobody light a match.
I have a whole other story about that, but we're not going to go there. Let's just say a bad first date when I pulled over to help somebody.
Well,
Eh,
so yeah, it is uncomfortable, and so we want to know that we're helping patients. That's our motivation, to help patients. And
but
will
I
this
think
intervention help them?
but I think what happens is that we get into this thing, as we've pointed out, it is likely, somewhere in the neighborhood of 10,000 C-collar applications for every actual spinal cord injury that we're dealing with. And I think we get lulled into this sense that, these things aren't really going to hurt you and they might help you if you have this injury. And we get stuck in this bias of not having actually seen that many bad injuries that we can change. Because keep in mind, within that number of thousands of spinal cord injuries, it's a much smaller subset that's delayed onset,
That
right?
were the suspected ones. Some
Right.
of them are obviously already.
Right. I have somebody I worked with very recently, and she did suffered a horrid car crash in her late teens and had a transection of her thoracic spine, but it was over at the moment of impact, right? So she's not in the category that we would have been talking about with backboards, and there are certainly those folks that have cervical spinal cord injuries that the C collar it doesn't really matter. The die was already cast, and so it's a vanishingly small number
The
that
number
will.
needed to collar, the NNC.
Yes, and I would assert that the number needed to collar is infinite to help, and I think the number needed to harm
Harm.
is also very large because we just don't have that many injuries. But I think that if we start with the population of those who are at acute risk for spinal cord injury, that is to say, they actually have a fracture and have some measure of edema to the cord, I would venture that the number needed to collar to hurt would be one. Like,
So I tend to be a minimalist. I've seen the literature. I've followed it over the last few decades, and moving more and more towards getting that collar off quickly, because they come in with the collar on, trying to use, clinical decision instruments or my clinical gestalt to say, we don't even need imaging. And even those who need imaging, I've removed the collar and sent them over for imaging and gotten some pushback sometimes from my friends in the diagnostic imaging department.
I get that same pushback, but I'll tell you that the imaging, the clinical clearance of cervical spines, unfortunately, I work in a very, very high malpractice area and have for almost a decade now. And it's almost reflexive because even missing a incidental, non-displaced
Spinal
transverse
process,
process,
tip off the spinal process or
right?
something like that. Yeah.
Yeah, is the medical legal risk is simply it's just simply too high.
It's
Um,
interesting, now you're talking about it because, I'm always talking about evidence-based medicine and the three pillars, and one of the pillars being the relevant information, the relevant literature. And we're talking about a bit of that now. And then clinical experience, of course, using our judgment. And then the final one is patients' values and preferences. And maybe that's where this fits in. Your practice is different than my practice because patients' values and expectations or preferences are, you miss anything, whether it's clinically important or not, there's a potential liability there that's larger in your jurisdiction than where I practice.
Absolutely. I mean, a missed fracture is, I'm not going to say that I CAT scan everybody's neck, but I will say I follow the Canadian C-spine rules judiciously, which means that those folks who have a mechanism, I mean, first of all, the ones I think that I am kind of notorious for not CTing are those where I'm like, this couldn't have caused a spinal cord injury. Like, that's not going to happen. Because I think that's one of the rules that people miss all the time, right? They're like, oh, the first step of the Canadian C-spine rules or the Nexus criteria is it has to be a patient in whom there is a mechanism that is suspect but low likelihood, right? Your pre-test probability is low, but not zero, right? And so where I'll have, for instance, a 5-year-old who is running and slides into first base, is not impacted by anybody and says that they're hurt. I'm not CTing that kid's neck. Absent osteogenesis imperfecta, a 5-year-old sliding into first base in a little league game, not coming into contact with anybody else, is not going to have a C collar, or it's not going to have a cervical spinal injury, rather. So that's fine. Likewise, I think the other rule that people forget is, and I've seen this happen a lot, is you will get the patient in who looks great, especially if they were intoxicated, who suffered the horrifying car crash, right? Especially nowadays with these cars that are amazing and will die to protect you. And, I'll have EMS bring somebody in and they'll be like, oh, the car flipped 17 times, doc, and look at it. This car looks like it was already compacted in the junkyard. And we cut the guy out of the car and he got up and tried to run away from us because he says he feels great and is just upset that his car is cracked. So we didn't put him in a C collar. And that person's getting a CT because, again, Nexus or Canadian C-spine rules, if the mechanism of injury is overwhelmingly likely to cause a cervical spinal injury, you get the scan. It's the middle. It's the maybe it could, maybe it doesn't, that I will apply the rule. And if the rule fits, I won't get the scan. But I think my definition of midline tenderness is maybe not the same as some other places. I mean, pretty much any neck tenderness is getting a scan because it's just very, very difficult to clear medical legally. But all that said, I don't put a collar on these folks. And I do get some pushback or have gotten some pushback and have actually run into places that have policies that say you can't get a cervical spine CT if you don't have the patient in a collar because it's too risky moving them over to the table.
And what are your thoughts on that? How risky is it moving, sliding board somebody? How much force do you have to
It's
cause
absolutely
an injury?
ridiculous. So going back again to this paper that I did in the 90s, it takes a huge amount of force to transect a spinal cord. Huge, well more than the 80 newtons of force that you get hanging your head off the edge of a bed, right? We've got 10 meters per second. I got to use the metric here because it's the only way I know gravity. 10 meters per second is the force of gravity, and an 8 kilogram head, that's 80 newtons of force. And
8 kilogram head? Is that how much a head weighs? 8 kilograms, 16,
yeah,
18 pounds? Okay, yeah.
that's what you would get if you hang their head off the bed, and it's not enough to transect the cord. And so I think it's very low risk. What I will say is, and maybe I'm gonna jump the gun here to where I'm at, and I'll ask you where you're at. To me, the only time that I see a utility for a cervical collar is in 3 patient populations. One is the flaccidly obtunded, right? The person that we're going to end up intubating, the person who is completely out, does not have protective reflexes, is, the horribly injured polytrauma that we're intubating, that, maybe we're chest tubing, we're doing all the other things, and they're out, and they're completely out. Because I don't think that person necessarily is going to be protecting, if they're not protecting their airway, they're certainly not going to protect their own cervical spine. And I think that as we are doing our thing, and as we're, I would imagine, I've never worked a trauma with you, but I would imagine that you do what I try to achieve, which is a calm room to minimize the amount of adrenaline flowing and to keep things as low key as possible. That's what I always try to model. I don't know if I'm always successful. Those who worked with me may say I'm not, but it's certainly my goal. But I think that as we are working around those patients who cannot even protect their own airway, the chance that we could accidentally bounce their head off of an IV pole in a rush to drag them from one cot to another or to drag them off to an imaging or whatever else, and perhaps put a fair amount of rotational force or a fair amount of push or pull to the head, further damaging the spinal column. Yeah, I'm worried about that enough that I think that that's where some kind of a cervical collar should be. Now, we didn't get all the way to talking about the Australians. So, side note, the Australians use soft cervical collars for this. They have those old foam ones that you put around that you used to see people walking around with them all the time. Not as much anymore. I think they were kind of given out for whiplash back in the day and were a marker that you were involved in a lawsuit that they kind of put on the front of it, whether the cervical spine has been clinically cleared or not, but it's really a warning to medical personnel to remind them to use that. And I'm fine with that, but I want something on there to identify to people, hey, look, this person is not capable of protecting their own, and we need to be darned careful because there's a real possibility. I think the person who is so under the influence of a substance who has also been involved in a trauma but is absolutely raging, and this is again going to the person with what we used to call excited delirium, now we may call, hypermetabolic syndrome alongside of substance use or psychosis or whatever other thing it is. But the person who is certainly hypermetabolic, is certainly enraged, is certainly extremely hyperactive, and is in the throes of something that is not under any kind of conscious control and is certainly not listening to the pain barriers that their body is putting up in other ways, also may not be able to protect their cervical spine. So as quickly as is reasonable to get them into a collar of sorts if they have a mechanism of injury consistent with a spinal cord injury, I think is reasonable as well. And I think that the last category that I'm half and half on, to be honest with you, is the person intoxicated with alcohol or opiates, where I believe it's to a level that they aren't going to feel the pain or experience the pain of moving their neck in such a way that they will protect their own from movement. And I think that that kind of falls in the category the same as the first one. I don't want to be the cause of moving their neck since they're not going to protect their own. I think anybody else shouldn't get a collar. If they don't fall into one of those three categories of folks, for me personally, there's no call for a collar. Those individuals that don't fall in one of those three categories are going to protect their own cervical spine more than adequately, because we don't see the people coming in paralyzed 3 days after the crash. We don't see the people coming, being found dead 3 days after the crash because of they moved their neck the wrong way and piffed their spinal column, and it just doesn't happen. And exposing all these people to all these collars and all of this kind of ridiculousness and some risk just doesn't make any sense to me. And don't get me wrong, I'm not suggesting that we have these people start playing a game of flag football. By no means am I saying, we should be doing chiropractic manipulation on their neck while they're out there to see if we can help with the pain. I'm just saying that we should allow nature's own system of self-splinting to do what it does and to encourage the patient not to move and to allow them to protect their own in the physiologic way that they're designed to do it.
I agree with you, Howie, in the severe trauma patient that you sort of described. I align with you on that substance use disorder, specifically opioids as well, because of pain. What about the people that have a lack of capacity? They've had an injury, a fall, a trauma, and it's not the severe ones that you were talking about like before, but they suffer from dementia. We have a large elderly population coming from long-term care facilities with falls and people with sepsis. So, they're not capable of really managing and keeping their necks still because they're delirious from sepsis. So two other categories, frail elderly, and often it's the frail elderly with sepsis who fell or something like that. Would you be protecting them in some capacity, putting a soft collar on them? That type of thing?
If we had a better move with soft collars or some marker type of collar, my worry with those frail elderly is most of those really frail elderly are kyphotic, and putting them into our
Hmm.
current designed collars is forcing their neck into an alignment that is unnatural for them. And we do stand a reasonable chance, certainly as reasonable a chance of them injuring themselves, of injuring them by doing it. And there are absolutely case reports of injury from that. And it goes back to, think about the other one that comes to mind is ankylosing spondylosis, right? I was present when it's believed that an odontoid fracture occurred. It wasn't me, from someone getting intubated.
I appreciate that nuance about the frail elderly because I'm trying to think this through, and that kyphosis often comes up. What about the sepsis delirium in the 50-year-old diabetic who's delirious?
I guess that I would put it the same way as I would put the obtunded with alcohol. If I truly believe that they are not capable of protecting themselves, I'm not against a soft collar, especially. I think that the hard collars with the attendant forcing them into an unnatural position, I think that septic person is going to start by holding their neck in a position that is the most comfortable, even if they are less responsive to normal painful stimuli. I think they're still going to try and hold as best they can in a position of most comfort. And so the thing I like the most about the soft collars, I'm not sure that there's good data about whether they cause the same rise in intracranial pressure as the hard collars do, but there's certainly just the physics of it. They don't force the neck into unnatural positions the same way
And
that the
and it might give them
the hard
some
collar do.
proprioceptive biofeedback to say,
Correct.
hey,
Don't do
just a little
this.
extra tap, tap, tap. You got this thing on your neck, so
Yep.
please don't move.
Yeah.
Um,
And again, I think that, we're not looking at, as we get into these subsets, there is a certain aspect of public health to this, right? Because if we're trying to create these rules to help this vanishingly small population, but we're hurting a larger population to do it, we have to kind of step back and say, huh. And so I agree with with the gist of what you're getting at, which is there should be some. I am not for, let's completely throw out all cervical collars. Let's make them go the way of x-ray machines in shoe stores, where we're just never ever going to do that again because the risks are so clearly greater than the benefit that this is just ridiculous. Let's not do this. I'm not for that. I agree that there is a place for a cervical collar. I prefer the soft over the rigid, but I agree that there is a place for them.
I think we've got a lot of common ground here. Is that place also in the pre-hospital setting from transporting them on a gurney, not on a hard board, but having some kind of spinal motion restriction when you're transporting them in an ambulance or in a helicopter, those types of things. I work in a rural environment in a snowy area of the world, and I've ridden in a lot of ambulances over the last 30 years, and it can be scary sometimes with the weather and the road conditions bouncing around in the back of an ambulance. And I've got a seatbelt on myself.
Heck, I've actually responded on snowmobiles and dragged people behind a snowmobile in a Stokes stretcher over the snowy ground, which I guarantee you is bouncing up about the. What I would say,
More than 80 newtons.
yeah. Well, I don't know. I probably not. I mean, gravity is gravity.
Yeah, you got
10
to
meters.
appreciate the gravity of the situation. Yeah, but
Thank
do
you.
you agree that that's a
What
reasonable?
I would say is this. I think that it should be viewed the same way as airway protection is. And that is to say, when a professional who applies training and experience and clinical gestalt to a particular patient that is in front of them, that they assess that the need for this intervention, that the benefits to this particular patient outweigh the risks to this particular patient, then we should have a method by which to immobilize the cervical spine. Be that a hard collar, be that a soft collar, or be that your pick of either. be that Miami J's, which I think are better than the hard collars, but not as good as the soft collars. I am not saying we need to throw out all cervical collars. What I am saying is that they should be treated the same way that we treat advanced airways. We should be.
I would opine that we should treat it the same way we should treat everything, that we should consider the patient in front of us, use it for the correct indication, and consider the potential benefits and potential harms of the intervention, and then apply it if we think it'll have a net benefit. And from reading the literature, that group is a small subset.
I agree with what you're saying. I guess the reason I use the statement of advanced airways is that we assess the airway of every patient, but it's a very small population that we move to an advanced airway adjunct of some kind. And to me, that's why I'm using that example, is because I think it's something that in every trauma patient, the need for it should be assessed. I agree with that. The same as the need for an advanced airway is assessed in every trauma patient. But I think that by the same ratio, that it's a vanishingly small population, that while we come across the car crash, it's a very small number of people in whom we then turn around and say they need to be intubated, or they need an IGEL, or even they need an NPA. I think we would, if we properly do this, we're going to find it's about that same small population that actually require a cervical collar or spinal motion restriction in the way of a mechanical barrier, be that a cervical collar, a soft collar, a backboard, whatever. But it should be considered in every patient. It should be part of our. I'm by no means am I suggesting that we should only assess for this need in the obtunded or the severe or the whatever. It should still be part of our kind of mental checks, right, on every trauma patient of, do I need this? And that's why I use the airway example.
So a good history followed by a directed physical exam, and then applying your clinical judgment, as opposed to a monosynaptic, since we're talking about spinal cords, a monosynaptic response of, you fall down, you get collar, right?
Yes.
Like, and so that's what I mean about routine. So it shouldn't just be a monosynaptic response. Here's the collar, because we got called for a trauma call, and it shouldn't also be no collars ever.
Right.
Okay.
But it should be rare. I mean, if we've got a paramedic or EMT or physician who's collaring 10, 20% of their traumas, someone needs to pull them aside and go, really? Really?
So you're talking about education then, right?
Yes.
You're talking about knowledge translation and,
absolutely,
that leaky pipe pathway of A, are you aware? The first A is, are you aware of the research or the data? And then, do you accept it? Do you acknowledge and accept? Yep, actually, that's what the data says. And then, can you actually apply it in your practice situation? Because, like you were saying, applying clinical decision instruments, you can't miss one. You have to have a nice round number of misses in your medical legal environment. And that's zero.
But I think the other thing is the acceptance is where we're getting a lot of pushback on this particular paper.
Are you getting acceptance pushback from a general group? Or is it from specifically emergency medicine, EMS, radiology, neurosurgery, neurology?
Yes.
Who is pushing?
Yes.
Oh, the answer is yes. Okay.
The answer is yes. Well, I think you're seeing pockets all over that have various biases towards everything, because as we're sitting here saying, hey, look, the number is very low, blah, 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 blah. I think the neurosurgeons would say, oh my God, I've seen lots of spinal cord injuries, because
selection bias. Yep.
Because they have a selection bias, right? They have seen lots of spinal cord injuries by comparison. What they're not seeing is the 100 people I sent
denominator.
Home. Yes,
the denominator.
They're not seeing the 10,000 actually that I sent home before I sent them the one. So I think
that means we should train together and learn together, because we're all on team patient, right? It's about the patient. Starts with patient care, ends with patient care. So we should have these multidisciplinary sections that involve not just physicians as well. We should have the PAs, the NPs, because they're involved in this care. We should have the nursing staff, because, the eyebrows will get raised if I'm just taking the collar off, just like when I send them over to diagnostic imaging and the nurse is taking the patient over and they're going, they don't have a collar, Dr. Milne.
Or, when what happened to me last night happens and they come and ask me to sign the form for the disbursement of the durable medical equipment of the Miami J collar they placed on the patient. And the
Yeah,
and the
so
or,
so we need
and the
to
or
have
and the order
everybody.
they insert and the order they insert underneath my name. And to the if the nurse that did that is listening, I don't blame you, but
Okay.
yeah,
Yeah, no, it's just the process.
that's the policy. You have
Yeah.
to, and I get it. But I think the other thing is, and I think this becomes the challenge to us too in EMS in particular, is we're all on team patient, but EMS is also on team population,
Oh, I
and
like that.
and so we also have to consider not only the patient in front of us, but the public health ramifications of any of these things. And
So, Howie,
so,
do you think that, because this is bringing up something to mind for me, I've just been talking about all the clinicians, all the healthcare clinicians that are involved in the spectrum of care from, the pre-hospital to being in the ICU and the neurosurgical unit and all that kind of stuff. But what about involving the patients too? Because, I think that there's going to be an expectation that the patient is going to be, why don't you have a collar on me? I thought if I was in an accident. Do you think that do you have an understanding of patients' values and
I
perspective?
haven't experienced that for the folks who are, because in my area we've been doing pre-hospital spinal injury clearance for decades. I mean, that
Okay.
was what my paper was about in '99. I've been around EMS units, and I've always, when I've been an EMS medical director, always allowed for pre-hospital spinal injury clearance in any of my protocols. And so I don't think that's as new of a thing. I think the minute you put a collar on somebody, they want it off. Like I,
And when you take it off, you're the best doctor ever.
it's the rare masochist that wants one of these things. And so I don't see that as much. I guess what I'm driving at is if we're putting tens of thousands of collars on people for possible benefit, I think the paper demonstrates very adequately that there isn't a benefit and that there really is harm. But even for the possible benefit of 1 out of 100,000 or 1 out of 1 million, then the question from an EMS standpoint for me becomes, if we removed C collars entirely, what would be the population effect? Would there be improved outcomes in trauma or worsened outcomes in trauma, or would it be a null effect? And I think that the answer is most likely a null effect, because I think that the harms of the C collar are, to people who don't have a cervical spinal injury, are rare. They basically boil down to airway and temporary pain and temporary muscle stiffness and the like. And as we point out, the number of spinal cord injuries that we are possibly protecting of those delayed onset spinal cord injuries are so low that on a population basis, this is going to be null. But I think that when you're talking EMS, you have to be thinking about that. I mean, this goes back to discussions of lots of different interventions in EMS, right? Should we be equipping all of them to handle home births? Well, no, because what we find out is that, we don't actually have that many massive hemorrhages after home birth, right? So you have to run a balance. And while I'll agree that C collars are not a huge cost and are not a huge time cost and are not a huge risk cost, the number of times we're putting these darn things on certainly
A
makes
cost
you
is a
think.
cost is a cost if there's no
Right,
benefit, right? And then
right.
these little like a little cost times by millions, a big number adds up. And that's not the only little cost. You're talking about, oh, TXA for X, Y, and Z doesn't cost a lot. What's the harm? And this thing and that thing. And then at the end of it, wow, this is really expensive.
Well, my favorite example on that one is some of these triage questions. I don't know if you guys have the same issue in Canada that we do in the States, but we have mandates for a lot of triage questions, including things that include: have you traveled to West Africa lately? Do you feel safe at home? Do you feel this? Do you feel that? And while you look at this and you say, okay, it's not that big of a deal, and we certainly don't want somebody getting abused at home to not share that with us. And I agree. I'm all for asking whether someone's safe at home. I don't want anyone to take from this that I don't. But if you look at a small emergency department here, where you're going to see 40,000 visits a year, and we have 30 seconds of question that are going to be asked of every patient, and these are a variety of triage questions, right? Are you COVID vaccinated? Did you get the flu shot? And these are questions that are hard stops in the United States. All emergency department patients have to do them by mandate. Like I said, some of them are kind of ridiculous. Have you traveled to Western Africa? Still looking at the Ebola. And that's it. All of these triage questions cost you 30 seconds.
It all adds
Right, well,
up.
that's 20,000 minutes in a small ED.
Yeah.
Right? And if you take 20,000 minutes and you divide that by 60, that's 333 person hours spent doing this, which is 0.6 of an FTE.
And thinking about the yield, yeah.
I think that we've reached that area of agreement that we both have, which is, look, it's a tool. It's got risks. The benefits are nebulous. Shouldn't be removed quite yet, but probably should not be used as routinely as it is currently being used by probably a good factor of 10, if not a factor of 100, and should be excluded from routine use and rather reserved for instances of professional judgment where it's actually seen as necessary. Is that a fair synopsis?
I think that's a fair synopsis. And my conclusion would be, if you're not on the front lines, you'll be on the sidelines.
Oh, way to get the plug in. Way to get the plug in. Ryan's going to love it. All right. So I will give you as the guest any summarizing thoughts. And I would strongly, again, encourage all of the listeners to this. Please take the time to listen to the Skeptic's Guide to Emergency Medicine, number 493. You Can't Hold Me Down with Spinal Motion Restrictions. Any other final thoughts, Dr. Milne?
Oh, well, Howie, thanks very much. And just remember, it's really important to think about why we do what we do. Realize that often we'll be standing on evidence that is pillars of salt and sand. And so don't get too holier than thou when it comes to wagging your fingers at other clinicians. I think we should be kinder to each other and understand that we really don't have a lot of great evidence. And, we're all on Team Patient and trying to do our best.
All right. I need one. I am Bat Doc.
I'm Bat Doc.
Thank you. All right. Thank you for listening to this. This has been So What, a Frontline production. And remember, folks, whether it's Schadenfreude or saving lives, we've got the best job in the world. Thanks for listening. See you next time. You have been listening to So What. I am your host, Howie Mell. My editor extraordinaire is Dave Polk, and we both thank you for all you do and all the times you do it. Thanks for listening. This has been a Frontline podcast.